So thank you so much to Jay and the organizers for allowing us to be a part of this all-star panel and this great meeting. And wanted to present a case of total exudative retinal detachment in a patient who's young, just 8 months old. And the patient comes in because some strabismus. And you look here, and the pupillary reflex is different. And it's not really leukochoria, but the reflex looks yellowish. So this is xanthochoria. And you could see these are images taken during an EUA. And these are the RetCam photos. And you have total retinal detachment in this eye. Other eye is normal. And you can see that there are a lot of exudates underneath the retina and vascular abnormalities. And here with any bad retinal detachment like this in a young child, we want to make sure that it's not retinoblastoma. And I don't think it's retinoblastoma, but we're going to rule it out. And we do a fluorescein angiography, which I think is really helpful in these cases. And here you see the diffuse telangiectasia and vascular abnormalities here, consistent, I think, with Coates disease. And we do an ultrasound. This worries me a little bit because there's a nodule here, there's a lesion posteriorly, and you have some material underneath the retina here in the subretinal fluid. But the material here underneath the retina is pretty homogeneous, not chunky and of different sizes like you may see with subretinal retinoblastoma. And so these are the images. And my diagnosis here was a total exudative retinal detachment from severe Coates disease. And visual acuity here is a light perception. And although this child is not super cooperative in our exams, I'm just curious at this point, what would our panelists do?
Dr. Bende, we would love to hear from you.
Hello.
Yeah, we can hear you, sir.
Yeah. Uh, so yes, I agree with the differential diagnosis. We need to roll out, and typically what I can see is like with the intraretinal, subretinal, exudative fluorescein angiography. My first diagnosis, obviously, I agree with you, will be like a Coates disease. Now, visual potential is practically not that much, but what we have a few cases, we drain subretinal fluid, not as a vitrectomy, because probably sometimes there is no space to enter. So probably transscleral drainage of the subretinal fluid. And once the height goes down, probably we try to do laser to all those telangiectatic vessels. The aim here is to probably, if we can settle down the retina, reduce the exudation, you are saving the eye, probably may not be vision. But there are a few cases we could just, had ambulatory vision, but aim is to prevent the eye going into painful blindness and NVG.
Yeah,
Great.
thank you for
Great.
your great pearls there. I agree that the visual prognosis is very guarded, so it's important to tell the parents that eye's not going to see very well, and this is about globe salvage and keeping your child comfortable. Um, and so I also agree that trying to drain the fluid from externally through the sclera is the way to go, because in children you don't want to make any iatrogenic breaks. Because one, it's very difficult to flatten the retina, which you have to if you want a retinopexy. And number two, these young eyes are very PVR-genic. And so external drainage with anterior chambered infusion, I think, is the way to go. If surgery is what's pursued, I think observation is okay too, depending on the reliability of the family and how your interactions are. But historically, I think a lot of these eyes were enucleated, but very less so these days.
True.
So here's the.
May
Mhm.
I ask quickly, did you show the FA on the other eye, or did I miss it?
Fluorescein is absolutely normal. Now, Coates disease, it's considered a unilateral disease, but us and several other groups have written papers showing that you can see fellow eye findings, but it tends to be very, very minimal and not visually significant. Some little telangiectasia or small aneurysms, maybe in about half of patients. Now with wide field angiography, we're realizing that it might be a bilateral phenomenon. Why it's so asymmetric, we don't have a genetic cause for this yet, but I think we still have a lot to learn about this. But examining the fellow eye is definitely very essential in pediatric retinopathies.
Perfect.
Well, also to differentiate, recently we had a similar case, and my primary diagnosis was obviously Coates disease. When I did ultrasonography, we have a few calcific spots, and we know that in Coates we do get a calcification also, probably, but at a scleral level. But the case which I had recently is showing some calcification in retinal Coates as well. So we asked for MRI. And then they came out to be probably we may dealing with a diffuse retinoblastoma. Ultimately, eye is enucleated. I do not have yet histopathology report this. I'm just talking about what happened last week. One of my colleagues ultimately enucleated. I'm waiting for a diagnosis, but primary diagnosis, exactly the picture is what I said. Primary diagnosis for me was spots actually. I'm surprised looking at calcific spots. But anyway, but what you mentioned about enucleation, when you are not sure about diagnosis and when there is no visual potential, might considering young age, probably you more are on an enucleation side rather than trying to do a conservative treatment.
Dr. Bendy, that's a very interesting story because we had a similar situation 2 weeks ago. And at Wills, I work very closely with Carol Shields and her team. And we do joint EUAs and procedures together. And she was referred a patient for Coates disease. But on B-scan, there was a lot of calcification. In a similar looking eye, though, with a total exudative detachment. And she had to take the eye out, and it was retinoblastoma.
Oh.
Okay, so this is what we did. So normally, so we do a peritomy here, and we're going to isolate the muscles here so that we have good control of the eye. And here, there was no anterior chamber because the lens was up against the cornea. So I inject Helon to create the anterior chamber so that we can put the infusion in. Instead of AC maintainers, I like putting the trocar cannula system into the through the limbus because it creates a very tight seal. And so that's what we're doing over here. And here, retinoblastoma is unlikely, but it was still sort of in the back of my mind. So I'm taking a biopsy here just in case, so I could send it to the pathology lab. And the drainage occurs spontaneously from that area. And the retinal detachment is improving and trying to express more of that posterior fluid, but not all of it is coming out. This is the important part here. Like Dr. Bende mentioned, the detachment is getting shallower now. So now we're making sure that the pars plana is available so that we can go through. If we wanted to do vitrectomy, most cases, traditionally, I think people would have taken the lens, but here we're making sure that the pars plana is attached now so that we can make sclerotomies. But I'm not going to use cannulas because the space is very tiny. And so I'm going directly into the sclera. And here, doing the vitrectomy, but there's not much vitreous because everything is so collapsed. And so we're not really taking anything out. And this is the cool part, using perfluorocarbon to push the remaining fluid out from inside, outside of the, through the sclerotomy. So we're draining the fluid without making a retinotomy. And now we're able to treat the lesions very well. And the aneurysms and the vasculature here, I'm doing fluid air exchange, and I'm instilling silicone oil in this eye. And it's not a regmatogenous detachment. So if it was a TRD, like for ROP or fever, no need for tamponade. But in this case, I know that the exudation is probably going to come back despite the good treatment with the laser. That tends to be the case for these really advanced eyes. And so I think the silicone oil helps to maintain that hydrostatic pressure to prevent the exudation from coming back. And the retina has been attached under silicone oil for the past year or so. And the child maintains light perception vision.
Excellent case, Yoshi. Excellent. When do you plan to remove the oil, or what is the plan about the oil?
Yeah, you saw that I used 5,000 centistokes. In the US, we usually use 1,000 for most cases if you have plans to take it out. And I use 5,000 if I think it's going to stay in there forever, which is the plan.
Okay. There is a very interesting question from Gopal that intraretinal calcification and osseous metaplasia may occur in coats. Any further tips to rule out RB? Do you have any thoughts on this?
I think the fluorescein is really indicative. And in retinoblastoma, this is a pearl I learned from Shiz Mukai, but the vessels kind of dive into lesions. Coats, you never see that. So I think fluorescein is very helpful in addition to the B-scan.
Okay.
And of course,
On the B scan,
brain image.
you did show the hyperreflectivity that is present posteriorly. I think it's more due to the exudation that has come towards the macula, which I think you saw it in your surgery also. So that is what shows the hyperreflectivity that you see, but never as much as calcification. So you can always say that it's probably exudation that has come.
Yep, absolutely.
Sorry, go ahead.
Oh, no,
And
I was just going to say, even in mild Coates disease with peripheral exudation, that exudation can track posteriorly into the fovea over time if you don't treat it and get that fibrotic knot where you could go from 2020 to 2200. And so it's definitely a part of the disease. Vinod, I'm sorry, I interrupted you.
No,
Yeah,
no,
last
no worries.
comment.
So I had a little comment. So regarding silicone oil removal in these cases. So once you see in the follow-up that the exudation is decreasing and the telangiectasia are well lasered, probably that's the time you can start planning the oil in these cases. I've done a couple of cases. They do really well. At least you are able to save the eye. In fact, I had a very interesting young girl who came to us. Being a girl, she had bilateral Coates disease. So she had been worked up for other abnormalities in terms of muscular dystrophies, but nothing came out. So one eye was already bad to begin with, neovascular glaucoma. The other eye had peripheral telangiectasias. So I took her up and did a good, nice vitrectomy followed by laser coagulation of the peripheral telangiectasia. So it's been 5 years now, and she's been doing really well.
That's
Excellent.
great. Bilateral Coates definitely is very scary because of all the systemic issues from the muscular dystrophies, some telomere diseases also. And so that's a great pearl.